In this lecture, we're going to continue our discussion of the cardiovascular system by looking at the role of blood vessels and maintaining blood pressure. Let's review the types of blood vessels you have. Remember, your cardiovascular system is a closed system, meaning there is no beginning or end. Remember, your heart is the pump, and it pumps blood into arteries. Arteries are large blood vessels that travel away from the heart, so they carry blood away. Arteries will branch into smaller blood vessels called arterioles, and arterioles feed into capillary beds. Capillary beds is where exchange of nutrients and gases occur between the blood and the tissues. Capillary beds then feed into small vessels called venules. Venules are tiny veins that then converge into larger veins that carry blood back to the heart. For the systemic circuit, arteries carry oxygen-rich blood and veins carry oxygen-poor blood. If you're looking at the pulmonary circuit, remember that's opposite. The pulmonary artery carries oxygen-poor blood, and the pulmonary veins carry oxygen-rich blood. So to define an artery, technically it carries blood away from the heart, and a vein carries blood back. Let's review from our anatomy kind of the histology of these blood vessels. Remember, the arteries that first leave the heart are called elastic arteries because they have a large amount of elastic fibers in the vessel wall. This makes them expand and contract or recoil to maintain their shape. This is important because these vessels are under a lot of pressure because they immediately leave the heart, and the ventricles can generate quite a bit of force. Elastic arteries then feed into muscular arteries. Remember the three layers of blood vessels. You have your tunica externa, which is connective tissue on the outside. Then you have the tunica media, which is smooth muscle. And then you have the tunica intima or interna, which is basically the endothelium, which is the epithelial lining of the lumen of the blood vessel. So remember, arteries have a large tunica media, a lot of smooth muscle, whereas veins have less smooth muscle. Now, an arteriole is a tiny artery. It has smooth muscle, so it has a tunica media, and then endothelium. And then it feeds into a capillary bed. And remember, capillaries only have the tunica intima. They basically are endothelial cells, one simple squamous cell thick. And this is important because this is where diffusion needs to occur. So you want to have a thin cell to maximize diffusion. And then remember, your veins have less smooth muscle, more connective tissue on the outside. Alright, so let's look at how blood flows through a blood vessel. You need to be aware of what we call the flow rate. And the flow rate is the volume of blood that moves through a vessel per unit time. Now this is looking at the volume of blood. This is different than velocity. Velocity would be the speed of the blood, through a vessel. This is the volume that moves through per a certain unit time. And there's an equation to determine flow rate. Flow rate is basically equal to the pressure gradient over resistance. So that's what the R stands for. So what the pressure gradient is it's the difference in pressure between one end of the vessel and the other end of the vessel. Now remember, the heart is a closed system. So the closer you are to the heart, the higher the pressure is going to be at that end, because he's the pump. So at the arterial end, you're going to have higher pressure than you would have as you travel away from the heart, and pressure would become less. The other thing that you have to take into account is resistance. And resistance is the hindrance or the opposition to blood flow through a vessel. So this picture is kind of showing, if you just looked at pressure gradient, if you had a blood vessel that's the same size, two blood vessels that are the same size, and you had a pressure difference between 50 millimeters of mercury at one end and 10 millimeters of mercury at the other, that pressure gradients, the difference between the two ends, would be 40 millimeters of mercury. Whereas if you had a higher pressure at this end, then you'd have a greater pressure gradient and blood flow would be faster. I think of the analogy of a hose. So if you have a hose and you want water to come out of the other end faster, what would you do? You would turn the nozzle so that more pressure is coming out and more water is coming out, and that would increase the flow. Well, it's the same thing your heart can do. If your heart wants to increase the pressure, he can contract with more force, and that would speed up the flow of blood through the vessel. Let's look more, though, at the resistance, because something that you need to realize is this is an inverse relationship. If you increase pressure gradient, you'd increase flow. If you increase resistance, you would decrease flow. So as resistance increases, flow rate would decrease. So what types of factors would affect the resistance in a blood vessel? Well, one is the viscosity of the blood, kind of the thickness of the blood, and it's basically the friction between molecules within the blood. So the big thing here is the number of red blood cells. If you have a larger hematocrit, you'd say, okay, your blood's a little thicker, you have more cells than you have fluid, and so that would increase the viscosity. Or sometimes, like in diabetics, if you have a large amount of glucose or solutes in your blood, that can also increase viscosity, or if you're dehydrated. The other thing is the length of the vessel. If you have a longer hose, it's going to take longer for the water to reach the other end. And the reason is it increases the surface area that water has to travel through, or your blood has to travel across. And that increased surface area increases resistance. Well, length in the case of your body pretty much remains constant. It's not really changing too often. If you do grow, you do end up having, more blood vessels and so forth. And then there's a greater length or distance you have to push blood through. But for the most part, length isn't changing. The other thing is the elasticity in the vessel wall. If you have a very elastic artery, it will give when the heart pumps, and therefore it would reduce resistance. If you have a vessel that has hardened, the walls of the artery do not give as much when the heart pumps, that's going to create more resistance to blood flow. And the last thing that affects resistance, and one of the most crucial things, is what we call peripheral resistance. So let's look a little more at the peripheral resistance and how that affects blood flow. So we define the peripheral resistance as the friction between the blood and the vessel wall. If you have two vessels, one that's smaller in diameter than the other, and you used to have the same volume of blood in that vessel. So we have 10 milliliters in a larger vessel and 10 milliliters in a smaller vessel. Which one has more peripheral resistance? Which one has more friction between the blood and the vessel wall? Well, in the smaller vessel, more surface area of the blood is exposed to the vessel wall than in a larger vessel. So if you have an increase in peripheral resistance as you do in this smaller vessel, blood flow would be slower. So you can see this here. If your pressure gradient was the same at both ends for both vessels, the smaller vessel would have a decrease in flow versus the larger vessel, because the larger vessel has a lower peripheral resistance. So the big thing that determines peripheral resistance is the radius, or the diameter of your blood vessel. What is the main thing in your body that affects the diameter of your blood vessels? Well, it would be your autonomic nervous system. Remember, you can cause vasoconstriction or vasodilation of blood vessels. So if you want to increase flow in a blood vessel, you would want to vasodilate. If you decrease the flow rate in a blood vessel, you would vasoconstrict, and less blood would flow to that area. So arteries, how do they distribute blood? We'll talk about how they change their diameter to affect resistance and blood pressure. Now, the first arteries that leave the heart are elastic arteries, and they offer little resistance because of their large diameter and their elastic properties. And so the aorta, which leaves the heart, when the ventricles contract, the elastic artery will expand. And that's to reduce resistance, so a lot of blood can get out of the ventricle and into the aorta. And then what will happen is it will recoil, because elastic recoils and pushes the blood forward. So the function of that is to maintain constant flow of blood through the capillaries despite the changes that are happening in the ventricles. Because if you think about it, if you didn't have that elastic property, your ventricle would contract and push blood in, and then when it relaxed, blood would flow back. Well, you don't want that. So the ventricles push the blood into the artery gives a little, and then when the ventricles relax, the artery recoils and pushes blood forward and keeps it moving forward during ventricular diastole. So blood pressure is the force that is exerted by the blood on the vessel wall. So when you take someone's blood pressure, you get two measurements. You get a top number and a bottom number. And the top number is your systolic pressure. And the systolic pressure would be the pressure in that blood vessel when the ventricles contract or during ventricular systole. The bottom number of your reading is your diastolic pressure. And this would be the minimum pressure in your blood vessel when the ventricles relax or go into diastole. So for example, you usually get, let's say, a blood pressure reading. In a perfect world, we say a perfect blood pressure would be 120 over 80. So your top number, 120, if you look at it, that's the pressure in the artery when your ventricle contracts. And then the 80, your bottom number, is your diastolic pressure, the pressure in your artery when the ventricles relax. So this picture here is you're looking at what we call a pulse wave. So your horizontal is time, and your vertical is pressure. Okay, so you're looking at the pressure changes that are happening in the artery over time. So when your ventricles contract, pressure increases, and this top number is your systolic pressure. And then when the ventricles relax, what happens is the pressure decreases, and this bottom pressure is your diastolic pressure. Now you'll see right here there's a little notch. You'll learn about this in lab when you do your cardiovascular lab. But this little notch is called the dicrotic notch. And what's happening here is that's when your ventricles relax and a little blood flows back and closes the semilunar valves. And then you'll see another little increase in pressure right here. That little increase in pressure is when the aorta recoils and pushes blood back forward. So that little notch is when the aorta recoils and pushes blood forward. Now you can figure out what your pulse pressure is. Pulse pressure is the difference between your systolic pressure and your diastolic pressure. So a pulse is the throb you feel when you palpate an artery and you trap it between usually like a bone and your two middle fingers. And you're feeling that throb. That throb is the difference between the systolic and the diastolic pressure. So to figure out your pulse pressure, we say pulse pressure equals your systolic pressure minus your diastolic pressure. So what would your pulse pressure be in this example? If your blood pressure is 120 over 80, then your pulse pressure would be 120 minus 80. So your pulse pressure would be 40 in this example. So that's a blood pressure reading you get usually clinically. You can also determine what we call your mean arterial pressure. And this is the average pressure in a vessel throughout the cardiac cycle. So it's not just when at a moment in time when the ventricles contract and the moment in time when your ventricles relax. It's the average pressure throughout that entire cycle. We call that the MAP, and you'll calculate this in lab when you do your cardiovascular lab. But MAP, or MAP, is equal to diastolic pressure plus 1/3 your pulse pressure. So in that previous example we did, if a blood pressure is 120/80, your MAP would equal 80, which was your diastolic pressure, plus, you just plug in your numbers, plus 1/3 your pulse pressure. And do you remember what your pulse pressure was? Your pulse pressure was your systolic minus diastolic. So it was 120 minus 80, which would be 40. So then you just solve for this. Basically 40 divided by 3, okay, which is 13.3, plus your diastolic pressure, 80. Okay, so in this example, your mean arterial pressure would be 93.3. Why wouldn't your mean arterial pressure just be your diastolic pressure plus your systolic pressure divided by 2? If you were to tell me take the average pressure in your blood vessel, that's how I would calculate it. But why isn't that the equation? Well, in the cardiac cycle, you spend less time in ventricular systole than you do in ventricular diastole. The ventricles contract very quickly, and then the rest of the time they're relaxed. They're relaxed more time-wise than they are contracting. So when you're taking the average arterial pressure, you have to take into account that the diastolic pressure lasts longer than the systolic pressure. So that's how they came up with the equation, diastolic pressure plus 1/3 systolic pressure minus diastolic pressure. The other thing is your mean arterial pressure can be determined by cardiac output times total peripheral resistance, because your cardiac output affects blood pressure and your peripheral resistance affects blood pressure. Now let's remember, we learned in our last lecture that cardiac output equals stroke volume, the amount of blood you pump each time the heart contracts, times your heart rate. And total peripheral resistance we just learned about. We learned about 4 factors that affect total peripheral resistance. We talked about viscosity, we talked about length, elasticity, and peripheral resistance, which is determined by the radius of the blood vessel. Now, that's total peripheral resistance, all those things combined. Now, length and elasticity we're going to kind of ignore because they're not huge factors. They remain consistent for the most part. So the 2 main factors that affect total peripheral resistance is viscosity, because that can change if you increase your hematocrit or you become dehydrated. And then the radius, because your autonomic nervous system is continuously causing vasoconstriction or vasodilation depending on your body's needs. What you can see here is we're starting to build our little concept map. It's getting bigger. So remember we learned in our last chapter, cardiac output, right? CO. What 2 things determine cardiac output? We learned heart rate and stroke volume, right? Those are the 2 things that influence your cardiac output. So we learned that in cardiac physiology. Well, now we're adding on to this. Cardiac output and total peripheral resistance affect mean arterial pressure, or our MAP. So our MAP is affected by cardiac output and total peripheral resistance. And we just discussed what the 2 main factors of total peripheral resistance are. We said the radius of the blood vessel, which is also known as peripheral resistance. So the radius of the blood vessel is going to be determined by vasoconstriction or vasodilation. And the other thing was viscosity of the blood. So you see what's happening? Our concept map is getting bigger. You have to start thinking this way. So if I want to increase my mean arterial pressure, I can increase cardiac output by increasing heart rate or stroke volume, or I can increase my total peripheral resistance by decreasing the radius, vasoconstriction, So you kind of can start to see how different things affect your overall arterial pressure. Now what we're going to do is, in our last chapter, we talked about all the things that can change heart rate, all the things that can change stroke volume. Remember, we talked about the autonomic nervous system, parasympathetic would decrease heart rate, sympathetic would increase. We talked about temperature. We talked about some hormones. Stroke volume, we talked about preload, afterload, sympathetic nervous system, hormones that affect stroke volume. Okay, we did that in our last lecture. Today, what we're going to do is we're going to look at things that affect total peripheral resistance and mean arterial pressure. Viscosity, I just mentioned a few things that will affect viscosity. Basically, your hematocrit, the number of red blood cells you have, will determine the viscosity of your blood. Or if you become dehydrated, where you have less fluid, more cells, or sometimes increased glucose can cause viscosity to increase. But for the most part, we're going to put that aside. Today, we're mostly going to focus on affecting the radius of our blood vessels, and how by affecting the radius, vasoconstriction and vasodilation, we can adjust our mean arterial pressure. Who's mostly vasoconstricting and vasodilating is the arterioles. Your aorta, for example, it can somewhat vasoconstrict and vasodilate, but it's a really large artery. It's not vasoconstricting and vasodilating, along with your other muscular arteries. They're mostly there to distribute the blood to the arterioles. And then it's your arterioles that are really changing in diameter to adjust blood pressure. So arterioles have a small radius. Okay, they have more resistance than your larger arteries, and they can adjust their diameter. And the reason they want to adjust their diameter is there's two reasons. One is they can vary the distribution of blood to various organs. So at some times, you want one organ to get more blood than other organs. You've heard me say, when we talked about the autonomic nervous system, you're going to shunt blood to the skeletal muscle. Well, that means those arterioles are going to dilate so that the skeletal muscle gets more of the cardiac output. Or you're going to shunt blood away from the skin, vasoconstrict those blood vessels, and vasodilate the vessels of the skeletal muscle. So by adjusting the diameter of your arterioles in different locations in your body, you can actually control which organs get the majority of the cardiac output at different times, because sometimes you might want to have the skin get more of the blood volume. It just depends on what your body's doing. The other reason is to regulate your overall systemic blood pressure. If you want your blood pressure overall to go up or down, your arterioles will change their diameter. Okay, so there's kind of two things going on. Arterioles will change their diameter to shunt blood to and from an organ so that an organ can get more or less of the blood that's being distributed in the cardiac output. Or they can overall, like systemically, vasoconstrict to bring blood pressure up. Now, arterioles are basically smooth muscle, and they always have some vascular tone. Remember we learned about sympathetic tone and partial constriction of blood vessels? And what maintains their constriction, okay, or lack of constriction when they vasodilate, is there's two things. There's what we call the myogenic activity of smooth muscle. And remember we learned that smooth muscle can generate their own contractions without input from the nervous system. So they can be intrinsically controlled, where they can contract or relax on their own. Or they can be influenced by extrinsic controls, and in this case, sympathetic nervous system. So there's two things maintaining the diameter of an arteriole. The activity of the smooth muscle, which is a local control, or what we call an intrinsic control. And then there's the sympathetic nervous system, which would be an extrinsic control. Now, we learned about intrinsic and extrinsic controls way back in Chapter 1. And now you're starting to see, when we're getting into cardiovascular system, that most of your organs have both an intrinsic control and an extrinsic control. And as we get into digestive, respiratory, renal, you're going to hear this again and again. So in this case, your extrinsic control is your sympathetic nervous system. And the purpose of the extrinsic control is to regulate your overall systemic blood pressure. So what that means is, in general, if your blood pressure drops, the goal of your sympathetic nervous system would be to cause vasoconstriction of the arterioles and bring blood pressure back up. Arterioles also have an intrinsic or local control, and this is going to be controlled by the myogenic activity of the smooth muscle. And the purpose of that is different. The purpose of the intrinsic control is to determine the distribution of the cardiac output. So this is to determine if that organ or tissue gets more or less blood. What we'll do is we'll look at the intrinsic controls and the extrinsic controls of arterial diameter. The intrinsic controls, they're local, and they're usually chemical signals. So what happens is, when a tissue is really metabolically active, he's going to need more of the blood supply, right? Because he's going to need more oxygen and he's going to need more glucose. So if you have a tissue that has increased its metabolic activity, it's going to trigger vasodilation of that arteriole so that that area can get more blood. The chemical signals that trigger the vasodilation, these chemical signals work on the smooth muscle and cause it to relax, therefore causing vasodilation. If you have an active tissue, there's going to be less oxygen in that area because the cells are using it really quickly. And there'll be an increase in carbon dioxide because that will be a product of the metabolism. So a decrease in oxygen and an increase in carbon dioxide will cause the smooth muscle of that vessel wall to relax and trigger vasodilation. Some other chemicals that can cause vasodilation is increased adenosine, which is a product of using ATP. Again, if you have a metabolically active tissue or an active tissue, it's using more ATP. And then nitric oxide will also cause vasodilation. And they learned about this in our tissues, and now they actually use nitrate pills, which they give people who may be suffering a heart attack, because it will cause vasodilation of those coronary arteries in their heart and hopefully increase blood flow back to the tissue. Some other chemicals that you might need to be aware of that cause vasodilation is histamine and prostaglandins. And we'll talk more about these when we get to your immune system. But prostaglandins, remember, are released when tissues are damaged. And histamine is released as part of the inflammation response. So when a tissue is damaged or you have an immune response in a tissue, you need to get more blood to that tissue. So these chemicals will cause vasodilation. Some other physical influences that can happen. Temperature. Heat will cause vasodilation. Cold will cause vasoconstriction of a blood vessel. And then there's what we call the myogenic response to stretch. So this is a physical influence. When the smooth muscle of that vessel wall gets stretched, or there's lack of stretch, it can trigger vasoconstriction or vasodilation. If you have an increase in perfusion, perfusion is flow of blood to that area. If there's an increase in blood flow, that's going to increase the stretch of the vessel wall. And what will happen is it will trigger vasoconstriction. This mechanism is used to control blood flow through the capillary bed, because you don't want blood flowing through the capillary bed too fast, because it won't allow exchange, or you don't want it moving too slow. If blood flow starts increasing, you may vasoconstrict that arteriole to slow down the velocity that blood's moving through that capillary bed. The opposite is also true. If there's all of a sudden a drop in blood to that area, a decrease in perfusion, a decrease in stretch, that blood vessel will dilate. And this is kind of protected because if there's an occlusion in that blood vessel, let's say, in the arteriole, and all of a sudden that capillary bed isn't getting any blood, that is not good. So what will happen is the vessel will vasodilate, hoping to return blood flow back to that area. So that's kind of the myogenic response to stretch. Now let's look at some extrinsic controls. Extrinsic is always your nervous system or hormones. So these are things that are going to affect vasoconstriction and vasodilation extrinsically. So we talked about your sympathetic nervous system. The purpose of your sympathetic nervous system when you go into fight or flight is to maintain your overall mean arterial pressure for your entire system. So overall you may increase blood pressure, but local regulation can override it for certain tissues that need increased blood flow. When you go into sympathetic, think about it in general. Okay, we're going to cause overall vasoconstriction of all arterioles in the body. If I vasoconstrict all arterioles of the body, then my blood pressure is going to go up. Well, for some tissues, when you're in sympathetic, you want more blood flow to those tissues. So then the local control will kick in and override that vasoconstriction. So you might overall vasoconstrict the majority of your arterioles when you're in sympathetic, but then tissues that need more blood, for example, when you're in sympathetic, your skeletal muscle, the arterioles there will vasodilate because their local controls will override the vasoconstriction. Even though you're vasodilating that local area, overall when you're in sympathetic, you'll increase your blood pressure. So hopefully that makes sense to you. The other thing is hormones, and you have a lot of hormones that we've kind of learned about already that increase blood pressure. And we mentioned these when we learned about the autonomic nervous system. Now we haven't really talked about this, but antidiuretic hormone, it can somewhat cause constriction of blood vessels. It's not a main regulator of blood pressure, but it can cause constriction. It also regulates blood pressure by increasing water reabsorption in the kidneys. So if you increase blood volume, you increase blood pressure. Remember your renin, angiotensin, aldosterone pathway? Well, angiotensin 2 causes systemic vasoconstriction. Therefore, it would increase blood pressure. We already learned about norepinephrine and epinephrine in your sympathetic nervous system. Now, when these hormones bind to alpha receptors, it causes vasoconstriction. So overall, it's going to increase your systemic blood pressure when you're in sympathetic. But there is a few areas where they actually cause dilation. Remember, skeletal muscle and cardiac blood vessels, because your heart's going to need a larger supply of the blood, and so will your skeletal muscles. And then we learned about your atrial natriuretic peptide, which was released by the right atrium when blood pressure gets too high. So if blood pressure gets too high, ANP gets released and it will cause vasodilation to bring your systemic blood pressure back down. All these hormones also help regulate blood pressure by adjusting the radius or the diameter of your blood vessels. So if the majority of your arterioles are vasoconstricting, your systemic blood pressure will go up. If the majority are dilating, then your blood pressure will go down. Alright, so here's one of these concept flow maps that you're learning to love. So we're looking at just things that affect total peripheral resistance. Now remember, peripheral resistance then goes on to affect mean arterial pressure. And the other side of this whole map is cardiac output that we learned about last chapter. So this part is just looking at total peripheral resistance. Two things that affect total peripheral resistance: arterial radii and blood viscosity. We talked about blood viscosity, number of red blood cells or your hematocrit, or I forgot to mention this. The other thing is the concentration of plasma proteins in the blood. That can also increase viscosity. But mostly we just talked about the arterial radius, things that are going to affect the diameter, vasoconstriction, vasodilation. This chart divides it into things that are intrinsically controlled and things that are extrinsically controlled. So we talked about things that are intrinsically controlled: the myogenic response to stretch, hot or cold, some chemicals that get released like histamine when you have an allergic reaction or immune response or tissues are damaged, and then those chemical changes that happen because of metabolic activity, decreases in oxygen, increases in carbon dioxide. Some extrinsic controls, would be hormones and sympathetic nervous system. So the sympathetic nervous system in general, overall, vasoconstricts most of the blood vessels, therefore increasing blood pressure. And then we talked about some of the hormones. Vasopressin, remember that's another name for ADH, antidiuretic hormone. You should be familiar with both of these terms because some people use vasopressin, some people use ADH. I tend to use antidiuretic hormone. Angiotensin II, and then your norepinephrine and epinephrine. So let's look at how your body regulates blood pressure. Okay, so we just talked about things that can cause the arterioles to change diameter. Now we're going to look at how your body responds to changes in blood pressure, what regulates the vasoconstriction and the vasodilation. Now short-term adjustments, so these are adjustments that occur within seconds. You might not realize it, but your blood pressure is constantly fluctuating even by you changing position. So when you go from a lying down position to a standing position, your blood pressure drops due to gravity. And so your body has to immediately respond to bring blood pressure back up. And it does it so efficiently that you don't even realize that that change in blood pressure happened. Now in some people, when their autonomic nervous system stops functioning as efficiently as it used to, and that kind of just happens with age, unfortunately. But for some people, if that response doesn't occur fast enough, when they stand up, their blood pressure doesn't get regulated quick enough and their blood pressure drops and they have lack of blood flow to the brain for a second and they can get dizzy. And in a real extreme case, it could cause them to pass out. So for most of us, this response or this reflex works really quickly and we don't even know that our blood pressure needed to be adjusted. It just happens automatically. How does this happen? It's called the baroreceptor reflex. And you have baroreceptors that are found in the carotid artery. You have some in the carotid artery in your neck and then in the aorta. And baroreceptors are monitoring blood pressure or mean arterial pressure. And when there's a change in the mean arterial pressure, it will initiate a reflex to counteract that change and bring you back into your blood pressure homeostasis, your normal blood pressure ranges. So the receptors are found in the carotid sinus or the aorta. It gets sent along a sensory neuron to the control center, which is found in the medulla. And in the medulla, depending on if you have a drop in pressure or an increase in pressure, decides what to do, and it sends a response out. Your efferent nervous system, specifically in this case because it's controlling the blood vessel diameter or cardiac muscle, it's going to go through your autonomic nervous system and adjust your parasympathetic or sympathetic activity. And you're going to test this in lab when you do your cardiovascular reflex. You're going to be testing the baroreceptor reflex. See how well it works. So let's say your blood pressure becomes elevated. Okay. That's going to be detected by the baroreceptors in your arteries. And the way it gets detected is if it's high, it will increase the firing rate of action potentials in the afferent neurons. And those afferent neurons travel to your cardiovascular center, which is in the medulla. So the cardiovascular center is getting an increase in action potentials from the baroreceptors, so he knows, okay, my blood pressure is too high. And so what he does is he initiates a response by decreasing sympathetic activity and increasing parasympathetic activity. Because if blood pressure is too high, we want to bring blood pressure back down to its normal range. So how are you going to bring blood pressure back down? Well, you're going to decrease heart rate, you're going to decrease stroke volume. So these two things are decreasing cardiac output, right? Then, by decreasing sympathetic activity, you're going to also cause arterial vasodilation. So we decrease cardiac output, we decrease peripheral resistance, therefore our mean arterial pressure is decreased and goes back down to normal. Now let's look at the other side of this reflex. Let's say your blood pressure drops. I stand up, my blood pressure plummets. Therefore, the baroreceptor will detect that drop in pressure. It decreases the firing rate of the afferent neurons, and the cardiovascular center picks up that the firing rate is lower, so it knows that blood pressure has dropped. So to counteract that drop in blood pressure, we're going to increase sympathetic activity, decrease parasympathetic activity. So that would increase my heart rate and increase my stroke volume, therefore increasing my cardiac output, and it would cause arterial vasoconstriction, which would increase total peripheral resistance. If I increase cardiac output and total peripheral resistance, that increases my blood pressure. So the baroreceptor reflex makes immediate adjustments to blood pressure. Now in some cases, it might not be just momentary shifts in blood pressure that you need to adjust. It might be longer term changes in blood pressure. And so you have long-term regulation, which in this case would involve hormones, okay? Because your nervous system's immediate, hormones take a little longer to kick in, but the results are longer lasting. Long-term regulation will kick in if your blood pressure has fluctuated from minutes to days. And the way that it adjusts blood pressure, instead of focusing on vasoconstriction and vasodilation, it adjusts blood pressure by adjusting your blood volume. So the hormones that play a role in adjusting blood volume, remember, are aldosterone and ADH. Because remember, aldosterone, this is going to involve the kidneys. Aldosterone increases sodium reabsorption in the kidneys, right? And if you reabsorb sodium, what follows it? Water. So if you're reabsorbing sodium, you're reabsorbing water, therefore you're increasing blood volume. And then remember, ADH directly is involved in the reabsorption of just water. So those two hormones will increase blood volume, therefore increase blood pressure. We have a mechanism for long-term regulation for having a decrease in blood pressure. You don't really have long-term regulation for increase in blood pressure, because that used to not be a problem. But now in our society, some people have chronic hypertension where their blood pressure is constantly high, and there's no real long-term regulation to counteract that. And what they've seen happen is your baroreceptors become adapted to that higher blood pressure, and so you start functioning at that higher blood pressure and there's no way to really counteract it. One thing they can do is they can give you drugs like diuretics that will cause you to lose fluid, therefore adjust your blood volume to bring your blood pressure back down. Or they can give you some drugs that block angiotensin II, ACE inhibitors. Remember, ACE was the enzyme. It's the angiotensin converting enzyme that we learned about. And if you block that enzyme, you can't convert angiotensin I to angiotensin II. And if you can't convert angiotensin II, then it won't trigger vasoconstriction. So you're just trying to counteract anything that might cause vasoconstriction and make your hypertension worse. So now we're going to look at the function of the capillaries. So we just finished the function of the arterioles. The arterioles' big function is to vasoconstrict or vasodilate. Two purposes: to control the overall systemic blood pressure and to control the distribution of blood to various tissues, so that some tissues can get more blood than others. Now your capillaries, their main function is to exchange material between the blood and the tissues. Capillary bed, they're this network of vessels, and they're usually fed by an arteriole and drained by a venule. And there's these little precapillary sphincters here that are smooth muscle that can respond to local controls. So what happens is these precapillary sphincters close off the capillary bed so that blood just is shunted straight through to the venule. This tissue is still getting some blood, okay? It's just not getting as much as the cardiac output. So if a tissue is not metabolically active, it might not need as much blood. If the tissue is very metabolically active, these sphincters will open up and feed the capillary bed, and so that you can have more exchange in that area. How exchange happens: you have your cells here, and then you have your interstitial fluid that surrounds the cells, or we also call that ECF, extracellular fluid. So you have to have exchange happening between the blood. So nutrients is going to move from the blood into the extracellular fluid, and then from the extracellular fluid into the cell. And waste products are moving the other way. They're moving from the cell to the interstitial or extracellular fluid, and then into the capillary to get into the blood. Now remember, for a cell, he's going to be wanting to get glucose and oxygen from the blood for cell metabolism, and he produces carbon dioxide as a waste product, and he'll also produce nitrogenous waste that needs to get into the blood. Now capillaries are designed to maximize the amount of diffusion that can occur. And why are they so good at diffusion? One is that they have the minimal diffusion distance. Capillaries are only one endothelial cell thick. They're a simple squamous cell, and that's the smallest cell you can get, and so that's going to maximize diffusion across that cell. The other thing is, when you look at the area of capillaries you have, you can see that the cross-sectional area of capillaries is the largest of any vessel. So you have more capillaries surface area-wise than you have any other vessel. That maximizes the area of exchange. Remember, we learned about if you increase surface area, that will increase the diffusion. And it's about 600 meters squared. I read that that's about the surface area of a tennis court. Okay, so if you laid all your capillaries flat and opened them up and laid them flat, you'd have about the surface area of a tennis court for exchange. And the other thing is, if you want to maximize diffusion, you want blood flowing slowly through the capillaries so you have more time for diffusion to occur. So if you look at this chart here at the velocity of blood flow through different vessels, obviously it's fastest in the aorta because you have the highest pressure, and it's even faster in the vena cava than it is in the capillaries. It's very slow through the capillaries, and that allows maximum time for diffusion to occur. Now if you look at a cross-section of a capillary, you can see your endothelial cell, or your simple squamous cell, and this in the center here would be the blood, and outside here is your extracellular fluid or your interstitial fluid. Now fat-soluble solutes can just pass through the endothelial cells because they're lipid-soluble. So oxygen and carbon dioxide are small and lipid-soluble, so they can just do simple diffusion across the vessel wall. Water-soluble solutes actually have to pass through pores, so there is little water-filled pores between the endothelial cells. Remember, some capillary beds are more porous than others. You have fenestrated capillaries that have more pores between the endothelial cells versus, for example, the blood-brain barrier, which has tight junctions, so they have less water-filled pores or none at all. Now, plasma proteins are too large to get out of the blood and into the interstitial fluid. That's important to know because plasma proteins will stay trapped in the blood. And if it's a protein that you do want to get out of the blood and into the tissues, for example, some of your protein hormones, they have to move through what we call vascular transport, which is basically there's a receptor and you'd have endocytosis and exocytosis on the other side. So let's look at how fluid moves across the capillary wall. So not only are you losing solutes and some proteins and gases, but fluid is also moving out of the plasma or the blood and into the interstitial fluid. There's two forces that determine how much fluid gets pushed out of the vessel wall. One force is what we call the plasma hydrostatic pressure. This is basically the blood pressure, the force that's being pushed on the vessel wall produced by the blood. So blood pressure is pushing fluid out of the vessel, or it's a force that's pushing out on the vessel wall. Then you have what's called the osmotic pressure. And osmotic pressure is basically the movement of water when water is being pulled down its concentration gradient. Now, there is always more protein in the blood in a healthy individual because of the plasma proteins like the albumin and all your clotting factors. So there's a lot more protein. So I'm going to put a P. Actually, I keep putting these dots, but you have very little or no protein in the interstitial fluid. That's my no P. You have a lot of protein in your cells. You have a lot of protein in the blood, but very little protein in the interstitial fluid. So what that means is you always have more solutes in the blood than you do in the interstitial fluid. So where's water going to want to move? Water is going to want to move from its higher concentration to its lower concentration, and that creates an osmotic pressure. So water is going to want to move into the vessel wall at the capillaries because it's moving down its concentration gradient. So you have blood pressure trying to push fluid out, and you have osmotic pressure, which is water wanting to move in. So who wins? What direction is fluid going to move? Is it going to move out of the blood vessel, or is it going to move into the blood vessel? Well, it depends if your hydrostatic pressure is greater than your osmotic pressure. Now, what ends up happening is it changes as you move through the capillary bed. So we call this the net filtration pressure. Which one wins? And this will determine if there's a net gain of fluid into the vessel or a net loss of fluid from the vessel. So what you end up seeing is it depends on the arterial end or the venous end of the capillary bed as you move through the capillary. So at the arterial end of the capillary, your blood pressure is usually about 35 millimeters of mercury. Okay, so your hydrostatic pressure is 35. Your osmotic pressure is about 25 millimeters of mercury. So who's greater? Well, in this case, at the arterial end of the capillary, your hydrostatic pressure is greater than your osmotic pressure. So what you get is a net filtration pressure of 10. That's the difference. You have a net filtration pressure of about 10 millimeters of mercury, which is going to force fluid out. So fluid's going to move out at the arterial end. Now, as you travel through the capillary bed, your blood pressure drops because the further you get from the heart, the lower your blood pressure is. So at the venous end of the capillary, it switches. Your hydrostatic pressure is 17 millimeters of mercury, while your osmotic pressure remains consistent. It's always 25 millimeters of mercury throughout the vessel. But what's changing is now the osmotic pressure is going to be greater than the blood pressure, the hydrostatic pressure. So now your net filtration pressure is driving fluid back into the vessel. The movement of fluid across a capillary is called bulk flow, and it involves two processes, ultrafiltration and reabsorption. Ultrafiltration is when fluid moves out of the capillary and into the interstitial fluid. So ultrafiltration, where are you going to have fluid moving out of the blood vessel? That's going to be at the arterial end. So you have fluid that moves into the interstitial fluid. And this is what this chart is showing. It's showing that at the arterial end, you have ultrafiltration here, fluid moving out. Somewhere along the way, as you move through the capillary, your osmotic pressure equals your blood pressure, so you have no net movement. And then as you get closer to the venous end, now your osmotic pressure starts to override your blood pressure because blood pressure is dropping. So at the venous end, you're going to have what we call reabsorption, which is movement of fluid back into the capillary. Okay, and that's going to occur at the venous end. So you're going to have fluid moving out into the interstitial fluid, and so at the arterial end, and then you're going to have that fluid move back in and be reabsorbed at the venous end. It's important that that fluid gets reabsorbed, because if you just had fluid move out of the capillary bed, what would happen to your overall blood volume? Well, your blood volume would drop, and you'd have swelling in your tissues. And if your blood volume drops, then your overall blood pressure will drop. So if you have fluid moving out, you need to reabsorb that fluid to maintain your blood volume. Even though you have reabsorption at the venous end, you still have more fluid that is filtered into the extracellular fluid than that gets reabsorbed. So you still need to return a lot of that fluid back to the blood. And the way you're going to return it back is through the lymph system. So wherever you usually have a capillary bed, so here's your capillary bed, you also have lymph vessels intertwined in there. In this picture, they're showing the lymph vessels as green. The lymph system is a one-way system. It's not a closed system like the cardiovascular system. What happens is when fluid leaks into the extracellular fluid here, okay, so I have fluid here in the extracellular fluid, when the hydrostatic pressure gets greater outside the vessel, lymph vessel, than inside the lymph vessel, fluid moves into the lymph vessel. Now once it gets in there, it's a one-way valve or flap, so the fluid can't get back out. So once the fluid moves into the lymph vessel, it's trapped there, and now you call it lymph. Now the lymph system is going to move that fluid through the lymph system and eventually dump it back into the blood. So it plays an important role in maintaining blood volume. In general, you leak about 3 liters of fluid into the tissues that doesn't get reabsorbed at the venous end. So your lymph system is responsible for returning about 3 liters of fluid back to the blood a day. Well, guess what? You have only 5 liters of blood. So if you lost 3 liters of fluid from your blood every day without it being returned, your blood pressure would plummet. The lymph system plays a very important role in this. And we say it's a pumpless system because it doesn't have a heart, obviously, so there's no force behind the lymph pushing it back to the blood. So how does the lymph get moved back towards the heart? In case you don't remember from anatomy, the lymph system eventually dumps the fluid back into the venous system right about where your jugular comes in and meets the subclavian vein. You have your right lymphatic duct, and then you have your thoracic lymphatic duct that dumps into the subclavian. So how does it get the fluid back if it doesn't have any pressure behind it? Well, along the lymph vessels you have lymph valves, okay, that they're showing here. And basically mostly skeletal muscle contraction squeezes the fluid up through the system, and once it gets past a valve, it can't go back the other way. So we call that the milking action of the skeletal muscle. The skeletal muscle contracts and pushes the fluid up, and then it can't come back down when the skeletal muscle relaxes because of the valves. The other thing is lymph vessels do have some smooth muscle in their vessel walls. So for example, when you go into sympathetic, it can cause constriction of those vessels somewhat and increase fluid back into the venous system. And also pressure changes in the thorax. So just respiratory changes, when you change the volume of your thoracic cavity, it creates a negative pressure that sucks fluid up into the thoracic cavity. As that fluid's being returned back to the venous system, as it goes through the vessels, it goes through lymph nodes where you have a lot of immune cells, T lymphocytes and B lymphocytes, that are then also checking the fluid for any foreign pathogens or antigens so that it can initiate an immune response if there happens to be an infection before you put it back into the venous system. Alright, so after blood moves through the capillaries and you have exchange of nutrients and waste products, the blood will enter into the venous system or the veins. And the function of the veins, remember, is to carry blood back to the heart. Veins compared to arteries, they have a larger diameter, a larger lumen, and they have little resistance to flow. Okay. And they're also under very low pressure because they're further away from the heart. So if you look here, this is a chart. You have blood pressure versus, I'd say my horizontal is distance from the heart, because your aorta is the closest, then you have your arteries, capillaries, and the vena cava's furthest away from the heart. I mean, it's coming back to the heart, but furthest away from when the force was generated. So you can see your systolic pressure and diastolic pressure. You can see that there's large changes. This is your pulse wave. But as you move away from the heart, your blood pressure becomes less and less. It's lower in the capillaries, and then it gets really low as you get into the vena cava, almost to where there's no pressure behind it. The other thing you should be aware of is most of your blood is in the venous system. You have more veins than you do arteries, and you can see here that more than 64 or about 60% of your blood is in the venous system compared to your arterial system and your capillaries and your heart or your pulmonary circuit. Now, how does blood move through the venous system? It's very similar to the lymph system because there's not very much pressure behind the blood to move it forward. So there's a few things. One is a pressure gradient. Okay, so this is my heart, and I have my atria right on top, my ventricles on the bottom, and I have my vena cavas coming into my right atria. Now what happens is I have blood in the vena cava, and when the atria relax, they expand, right? And when they expand, it creates like a suction, because now pressure is lower in the atria than it is in the vena cava, and that basically sucks the fluid into the atria. Okay, so that's what I mean by a pressure gradient. The other thing is you also have one-way valves and skeletal muscle contraction, which is very similar to what we just talked about in lymph. So your veins have valves, one-way valves, and the skeletal muscle will contract and push the fluid up past a valve, and then when the blood tries to come back down, it can't because the valve closes until the muscle contracts again and pushes it up even further. So it's kind of a slow process, but it's increasing your venous return. So the idea is if you want to increase venous return back to the heart, exercise would speed that up because your skeletal muscles are being active. Another problem is people that are in bed rest, okay, and are not moving around. Their blood can sit in their venous system, and it can lead to an increased chance of blood clots, because if blood sits too long in one spot, it can spontaneously clot, and so it's dangerous. So that's why if you're in bed rest or in the hospital, they'll put little leg compression socks on that massage your legs, or they'll try to get you up and moving to prevent that from happening. The other thing is what we call the respiratory pump, which this is breathing basically. As you breathe, you change the volume of your thoracic cavity, and that's the same thing we talked about the heart. When your thoracic cavity expands, it sucks fluid up into the thoracic cavity. Cardiac suction is what I already described. Cardiac suction is when the atria relax and suck fluid in. And then there is some smooth muscle in the veins, so sympathetic activity can increase venous return, because you can have some vasoconstriction of the veins, which will increase venous return. So all these things would increase venous return back to the heart. This little flowchart, another one of your concept maps, all the things that would increase venous return we just talked about: cardiac suction, valves, sympathetic nervous system, skeletal muscle, respiratory pump. Now, one thing we didn't talk about is blood volume. If you increase blood volume, you can increase venous return, and that's going to involve your kidneys, because if you retain sodium or salt and water, that would increase blood volume, therefore increase venous return. Now, to get our picture bigger, if you increase venous return, remember we talked about that would increase your end diastolic volume, basically the volume of blood that fills into your ventricles. And remember we talked about that was called preload. If you increase the load of blood into the ventricles, it increases the stretch of the ventricles. Remember Frank Starling's law that we talked about in our last lecture? And if you stretch the ventricles more, they contract with more force. And if they contract with more force, you increase your stroke volume. And if you increase your stroke volume, you increase your cardiac output. And guess what? If you increase your cardiac output, you increase your mean arterial pressure. So see how our concept map is getting bigger? Alright, so here it is. It's a little scary. And this isn't even everything we talked about. A lot of what we already talked about, but not everything. So this is a little summary. All the things that affect mean arterial pressure. On Blackboard, I put a little activity called a blood pressure concept map. And what it is you can print out all these terms, and you can cut them up, and you can make your own little concept map like this. Basically, who relates to who, who's going to increase what, and there's no one answer to it. I could have 3 different students arrange the terms differently, but all still be correct, because it's just how you relate them to each other. For example, let's summarize. Mean arterial blood pressure. 2 things that affect it: cardiac output and total peripheral resistance. In our last lecture, we talked about cardiac output. We talked about the things that affect heart rate and the things that affect stroke volume. Obviously, your autonomic nervous system. We just talked about venous return. Let's see. Over here for total peripheral resistance, 2 main things: blood viscosity and arterial radius. In this lecture, we mostly focused on things that would affect the arterial radius. We talked about Local metabolic controls, that was the myogenic response, smooth muscle response. Okay, chemicals that are released will cause vasoconstriction or vasodilation. And then we talked about your extrinsic controls, which were the nervous system, sympathetic nervous system, and epinephrine. And then we talked about hormones, ADH and angiotensin II. Now, what's really crazy about this chart, and nice, is you're also getting into how blood volume can affect all this. Vasopressin, and then the renin-angiotensin-aldosterone system we learned about will increase salt and water retention. And if you increase salt and water retention, you increase blood volume, which increases venous return, which increases stroke volume, which increases cardiac output, which will increase mean arterial pressure. See how we got there? So guess what? When we get to the kidneys, we're going to revisit this whole idea of how the kidneys regulate blood pressure. So it's pretty crazy and it's a little overwhelming, but you can kind of see now that blood pressure is a complicated thing. My grandmother, for example, she gets so upset with the doctor because she suffers from hypertension and she doesn't understand why the doctor can't tell her what's causing her high blood pressure. Well, can you see now why that's a tough answer? There's so many factors and things that could be causing that blood pressure to increase. So what they basically do is just try to counteract the blood pressure by either affecting blood volume or affecting vasoconstriction. Something else that's not even in this is genetics. Okay, blood pressure can also be affected by genetics. Some people just tend to genetically have lower hypotension, whereas some have genetically hypertension. So there's a whole lot of factors that go in there. Also lifestyle. Lifestyle is not even in here either. Diet. There you go. That's blood pressure in a nutshell. Instead of trying to memorize this chart, just think through it logically. If I increase stroke volume, what's going to happen to my cardiac output? What types of things would increase mean arterial pressure? What things would decrease mean arterial pressure? Okay, you got to start thinking like that because you can guess I'm going to ask you stuff like that on the test, right? Which of the following would not increase stroke volume? Or which of the following would decrease heart rate? So just try to think through it logically. Alright, one last little thing I want to talk about since we're on the cardiovascular system is about cardiovascular disease, because many of you are going to go into healthcare and you're going to work with a lot of people that might suffer from cardiovascular disease. Even if you aren't going into healthcare, cardiovascular disease accounts for over half of all deaths in the United States. So what that means is either someone you will know, someone in your family may suffer from cardiovascular disease, or it's something we all need to be aware of because it could affect our health. A myocardial infarction is actually a heart attack. And what causes it is you have your coronary arteries that are small little arteries that travel and feed the cardiac muscle with blood. And we talked about that cardiac muscle always has to have a constant supply of blood because if it doesn't have oxygen, it can easily die. And when it dies, it turns to scar tissue and then it won't contract properly, and then your heart won't function efficiently to pump blood. What causes a heart attack is some of the muscle tissue isn't receiving blood and it becomes hypoxic, lack of oxygen, and the cells will quickly die. And what mostly causes that is a blockage in a coronary artery or a small blood vessel feeding the heart. Now, some people can survive a heart attack, but usually that tissue remains as scar tissue, so the heart might not function as efficiently. And it's really dangerous if it happens on the left ventricle, so it kind of depends on the amount of tissue that gets affected, how efficient your heart will be afterwards, and if you can survive. And then also, like, the left side's dangerous because the right side only has to pump to the lungs. Left side has to generate quite a bit of force to pump blood throughout the system. So what causes the arteries to get blocked? Well, there's atherosclerosis, which is hardening of the arteries, which kind of goes along with what we call arterial stenosis, which is technically the narrowing of the arteries. But basically you have plaque that builds up. It's like a fatty plaque. A lot of times involves cholesterol and other substances that form on the inner walls of the arteries. So this is a cross section of a nice open artery. Here's the lumen of the artery. It's nice and open. Blood can flow through there. This would be an artery that has plaque building up on the wall. And you can see all this plaque here. And so what happens to the lumen is it gets really narrow. So you'll have less of an area for blood to flow through. And though a lot of times they can look at a coronary artery and say, okay, it's 50% blocked or it's 90% blocked. If it's 90% blocked, there's not much room for the blood to get through. So what causes this atherosclerosis? Atherosclerosis is the hardening which goes along with the narrowing of the artery. They've actually found that it's kind of like inflammation of the artery wall. And you have your normal endothelial cells right here, lining the lumen. And then you have connective tissue under that with some smooth muscle cells. What happens is your low density cholesterol kind of starts to accumulate because the endothelial cells will take it up. It will accumulate it under the endothelial cells down here in this connective tissue. And then what happens is it turns into kind of a state of inflammation. You have macrophages which will come and try to ingest the cholesterol, and they become what we call these foam cells. The macrophages release chemicals that initiate inflammation. And when it releases those chemicals can cause, they found, the smooth muscle cells to start to divide. They make your wall thicker, and the plaque starts to build up and it starts to move into the lumen. What's really dangerous is that plaque can rupture. It can break through the endothelial cells and it can rupture. Usually blood flows nice and smoothly as long as the endothelial cells are nice and smooth and intact. But if an endothelial cell is damaged and you have collagen or anything that roughens up the surface of the lumen, it can cause blood to clot. And then now you have blood clots which can block arteries and so forth. So it's pretty dangerous. And now that we've learned that it's kind of a process of inflammation, they are running some blood tests that test for chemicals, general chemicals that are high when you have inflammation in your body. And if they're high, they're using those as a marker that you may have atherosclerosis or be at risk because you have a high amount of these chemicals that are elevated when you have inflammation. So how do we treat this cardiovascular disease? Well, the first thing they can say is you need to change your lifestyle and diet. So they could tell you diet, exercise, lower your lipid intake or cholesterol intake. Or they can give you drugs to lower your cholesterol. Or hypertension can also lead to an increase in risk for narrowing of the arteries. And the reason is high blood pressure tears at the lumen also, and it could cause roughening of the arterial wall, which makes things more likely to stick to the wall and build plaque. Then what they can do is if they think you have narrowing of one of your important coronary arteries and you might be at risk of a myocardial infarction, is they can go in and look, and they do what is called an angiogram, where they inject dye into usually a vein in your leg, and then they can take a picture of your coronary arteries and see which artery might be blocked. And if they see blockage, then what they can do is they can do what is called an angioplasty. And they basically take a catheter and they usually insert it again into a vein in your leg and they snake it through your venous system, which I find amazing that they're able to do. They navigate the catheter through the venous system and they can get it into the coronary artery where there's blockage. And they can do a few things. At the end of that catheter, sometimes they have a balloon that they can inflate. And they inflate the balloon, and you can see in this picture here, here's your balloon. They can inflate it, and it basically presses the plaque up against the wall of the artery, and they're hoping that that will open up the lumen more. So they might just use a balloon, but you're still risking the chance that that plaque builds back up and closes off later on. So what they do a lot of times is they also insert what we call a stent, which is kind of this metal mesh brown tube, and they basically can insert that stent, which they're showing here, and leave it in there, and that will hopefully keep the artery open for blood flow. But a lot of times you have to then take anticoagulants to keep your blood from clotting still and thin your blood. Now they usually will use stents if the blockage isn't too severe, or sometimes if you're older and they don't think that you can withstand open heart surgery, okay, because this is less invasive. Now what's more invasive, but the results from it are longer lasting, a little more permanent, is coronary bypass surgery. And with coronary bypass surgery, it's open heart surgery, so they have to open up your thoracic cavity. So they basically cut through your rib cage, open you up, stop the heart, and put you on a bypass machine. And then what they do is they sew a blood vessel from somewhere else in your body around the blockage. So now, if we go back to this picture here, so if my blockage is right here, what they do is they'll take a vessel and they'll sew another pathway. They'll attach one end of the vessel up here before the blockage, and then they'll attach the other end on the other side of the blockage. So what that creates is a little bypass. Basically, blood can now just flow around the blockage through this new vessel and get to the area that that vessel fed. If you have any questions, you can always contact me. And that is it. Hope you guys have a good week.